Welcome to the conference session titled Transplantation. Welcome to the conference session titled Cardiovascular Concerns After BMT. Thank you for joining us. My name is Nyari Sireu, Patient and Professional Programs Coordinator. As we get started, the AMDSIF would like to recognize the generous support of our corporate sponsors. At the diamond level, we have Alexion and Novartis, and at the gold level, we have Apellis and Genentech. We also recognize the support of our patients, families, and caregivers in making the conference happen today. Immediately following the presentation, there will be a question and answer session. When asking your questions, I will ask that you please do not share any private health information, as our speaker cannot answer any specific questions related to your healthcare. Today's specialist is cardio-oncologist June-Wha Rhee. Dr. Rhee puts listening first. She aims to understand patients' desires, priorities, concerns, and experiences. Fascinated with the heart, she has dedicated her career to finding new ways to prevent or minimize cardiovascular complications from transplant and cancer treatment. Her current research, funded by the National Institutes of Health and the American Heart Association, delves into the mechanisms behind drug-induced cardiovascular complications. And with that said, welcome, Dr. Rhee.
Thank you so much for the opportunity to give a talk today regarding cardiovascular concerns after stem cell transplantation. So in terms of the outline of the talk today, I will first review some of the heart complications that happen after transplantation. And then we'll also talk about how we can protect our heart health during and after transplantation. And I'll sprinkle a little bit about our current ongoing research. And then at the end, we'll have a questions and answers. And I would like to spend actually more time addressing any questions that patients might have. So this is very classic, all thanks to our hematologists and supportive care staffs. There have been a really steady increase in the number of transplantation happening annually. We see that there have been more than 20,000 transplantations happening in the US. This is actually autologous transplantation, but same thing with the allogeneic transplantation, as you heard from Dr. Nakamura's talk. There have been an increasing age among the recipients of the transplantations. So coinciding with this pattern, we actually see some increased number of cardiovascular or heart diseases happening among the transplant recipients. While this takes up a very small fraction of patients who might pass away from the cardiovascular diseases, we see that the risk of mortality is higher among the transplantation recipients compared to matched control. And then this is most driven by what's called heart dysfunction or cardiomyopathy, where patients with transplantation recipient who underwent transplantation may suffer from a higher risk of heart failure or heart dysfunction compared to their matched control. So then the next question is, okay, then what type of heart dysfunction or cardiovascular diseases are we talking about? So we'll talk about some of the types of the cardiovascular diseases that could happen after transplantation. The most frequent disease that we see is what's called atrial fibrillation. And this happens mostly within the first 100 days after transplantation. And atrial fibrillation refers to irregular heartbeats coming from the upper chambers of the heart. And we'll spend a little more time in the following section to talk about what it is and how to diagnose it and how to treat it. The number 2 most common cardiovascular diseases after transplantation is what's called heart failure, which I really hate the name. It's not really a failure. It's a dysfunction of the heart pumping function. And we'll again talk about these two, heart failure and atrial fibrillation, more in detail in the following section. Rather rarely, but it can happen, some other complications can happen, such as coronary artery disease or heart attack, stroke, or any clot formation or valvular diseases, but these are rather minority of the diseases we see among the patients. So, and it might be just good to kind of talk about the timing of these heart complications. Again, The most common complication is atrial fibrillation, and it happens probably the most commonly immediately after the transplantation, the first 100 days. And because the heart is a little bit irritable in the setting of all the stress and transplantation. And then the risk actually goes down and heart becomes kind of like heart cools down and becomes calm. And then as patients survive their transplantation with more, with kind of as a late outcome, there's a little bit of slight increase in risk of atrial fibrillation. In terms of heart dysfunction, apologize for the font font size and all that. This is a little bit different from what I submitted. But heart dysfunction again happens immediately after the transplantation when the heart is irritable, and then again the risk goes down and becomes quiet. But again, it happens again as a late complication. And heart attack and stroke are more the late complications of the transplantation that could happen years after, associated with more increased risk of increased rates of aging. So today, again, we'll primarily focus on the atrial fibrillation and heart dysfunction. So then one may wonder who is at risk for heart complication. There are certainly a patient-specific risk factors. The older we are, the more at a risk for heart diseases in general. So age is one factor. Some other underlying heart disease-related risk factors like high blood pressure, high cholesterol, or kidney disease could be risk factors. But there are also some treatment or primary disease, in this case, MDS or aplastic anemia, related risk factors as well. So in terms of, in exposures related to the underlying conditions, when before the transplantation, when we treat for primary disease like MDS, there can be a therapeutic exposure-related complications. Some of the cancer treatments can potentially have some impact on the heart. And then there's a stress of the transplantation. And after transplantation, some people may have more maintenance therapies or GVHD, and those can also influence the heart health. So it's not just the transplantation, it is the spectrum, all the exposures that can influence the heart health. So again, in summary, there can be some prior disease, prior transplantation exposure in terms of chemotherapies or radiation to the chest or other targeted therapies that can influence the heart health. And there can be transplant-specific exposures. And then any stress, actually, like whether stress of infection or sepsis or any major fluid shift that can also stress the heart and affect the heart function. And lastly, this is something that I wanted to emphasize. After transplantation, there can be what's called emergence of heart disease risk factors like high blood pressure, high cholesterol, or kidney disease that could also influence one's heart health. So that's something that we'll talk about at the end of the section. So kind of going deeper into, again, the two most common heart complications. One is atrial fibrillation and heart failure. So what is atrial fibrillation? So I always explain to my patients that heart is like an electrical pump. So first of all, you need to pump the blood to maintain the blood supply in the body, but you need an electrical activity to tell the heart to pump the blood. So the way the heart functions is that there's a pacemaker cells say, hey, you got a beat. And then the upper chamber beats, and then the electrical signal goes down to the lower chamber, and the lower chamber beats, and then ultimately pump the blood for our body. So it's very coordinated electrical activity. When there's atrial fibrillation happens, as you can see in this blue, I'm not sure what I can get the cursor here, the blue area, now instead of upper chambers are waiting for the signal for pacemakers, it's just fibrillating, it's not contracting. And it's rapidly sending the signal to the lower chambers to contract. So one of the major complications of atrial fibrillation is fast heart rate. Patient can have palpitation and having the heart rate increase. Another thing is, as you can imagine, since it's not a coordinated activity of the upper chamber, it can be a nidus for clot formation. So, sometimes patients with atrial fibrillation in general can be at a risk for clot formation in the heart, which can be a risk factor for stroke. So what are the common symptoms and signs, and what are the risk factors for atrial fibrillation? Most common symptoms are palpitation. Hey, like, I feel like my heart is racing. Or, sometimes people can feel lightheaded, or sometimes people may just have abnormal sensation around the chest. Since the heart rate is fast, patient can have shortness of breath on exertion or have fatigue. But surprisingly, about 30% of the patients don't have any symptoms. So that's one caveat of the atrial fibrillation. Patients just feel fine, but then when they come to the clinic and they're found to be in atrial fibrillation. So then who are at risk for atrial fibrillation? As we get older, we are at a risk for atrial fibrillation, and female and gender in general are at a higher risk than the male in general, and any major fluid shift in the body, stress like fever, infection, those can be risk factors. And sorry for the coffee drinker, but caffeine can also irritate the heart. And certain cancer medications are associated with atrial fibrillation, and most importantly, around the time of the transplantation, atrial fibrillation can also happen. So then how do we diagnose and monitor? We can, probably everybody had heard about EKG. We can do an EKG to look at the heart rhythm, but it's a snapshot of it. So if you're not in AFib at the time, because people can be in and out of AFib, then we can't really diagnose at the time. So these days we use what's called event monitor, which is like the Band-Aid-like structure that you put it on the chest, and you just forget about it for 2 weeks. And they will constantly record your electrical activity of the heart and see whether there's any presence of atrial fibrillation. Since it is hard to capture it, generally we don't do the diagnostic screening for all the patients. We do the diagnostic workup when there's a symptoms or when the heart rate is abnormally fast. So the last thing is, how do we treat atrial fibrillation? Sometimes we do nothing. We can observe as long as the patients are asymptomatic and doing fine, but sometimes we need to slow down the patient's heart rate by using the medication, or need to reset the heart rhythm with medications. When medications are not effective, and then sometimes we need to reset the heart by shocking the heart or do a procedure called catheter ablation. And sometimes we use blood thinning medication to prevent the clot formation, but with caution, since many of our patients have low platelets count. So only after the platelet count recovers, then we consider blood thinning medication. So next thing is about heart failure. Again, heart is like a pump, and when the pump doesn't function and doesn't pump the blood appropriately, then it can cause heart failure. I'm not sure whether people are familiar with a number called ejection fraction. So when we talk about heart failure, we always talk about ejection fraction. What that means is that, let's say the pump had 100 milliliter of blood, and then in one heartbeat, you pump 65 milliliter, and we call that as a 65%. For normal heart function, it is about 55 to 70%. That's the way that we quantify the heart function. And when somebody has heart dysfunction, this number can be low. And this is actually the number that we look closely before patients get transplanted to make sure the heart can endure the stress of the transplantation. So what are the symptoms of heart failure? Generally, it's more shortness of breath on exertion. Hey, like doc, I used to be able to do A, B, and C, but now I can only do A. And another common questions are swelling of the ankle or feet. That doesn't go away even after in the morning raising the legs up, or just weight gain without really eating anything more, or fatigue. And some of the common causes of heart failure in general is a blockage of the heart vessel called coronary artery disease or heart attack that's causing the heart damage. But in our cohort, that's not as common as the next one, which is exposure to potentially cardiotoxic therapies and stress. So any prior chemotherapies can be an insult to the heart. Any stress like infection or the fluid shift can also be stress to the heart. And sometimes, and the good news is that the heart function can be reversible. So it's something that we optimize and monitor. The last thing is something in connection with the atrial fibrillation. When heart is beating really, really fast, then as you can imagine, you're kind of, you work so hard, and eventually you burn out. So we call it as a fast heart rate induced heart dysfunction, which can happen in association with atrial fibrillation. But again, as we control atrial fibrillation, the heart function generally restores. So how do we diagnose and screen? The number one is echocardiogram, echocardiography, which is the ultrasound of the heart. I'm pretty sure some of the patients here already had it. And when there's any concern, then we sometimes do an MRI or CT or stress testing. So this is kind of the example of echocardiography just for fun. This is a normal heart function. This area is what's called left ventricle, which is a powerhouse of the heart that's pumping the blood pretty vigorously. And when there's a dysfunction, it doesn't pump the blood as much. You can see it's not as vigorous. And that's how we quantify the heart function using echocardiography. So again, how do we monitor for heart failure? It's monitoring at home regarding the weight change, symptom, exercise tolerability, and blood pressure. And then how do we treat? We can give medication to protect the heart function, medication to get rid of the extra fluid. But most importantly, we also recommend our patients to lower their salt intake to 2 grams a day, because salt is what really keeping and retaining the fluid in the body, and we want to get rid of the extra fluid. So those are heart failure and atrial fibrillation in general, that what we do with as a clinician. But patients sometimes ask me, hey, what can I do to improve my heart health during and after transplantation? So this is what's called Life Essential 8, that's recommended by American Heart Association. It includes you eat better, be more active, manage your sugar, manage your weight, control cholesterol, manage blood pressure, quit tobacco, and get healthy sleep. Among these 8 items, I will talk about 4 that's highlighted in red that could be more relevant to our patients. So number 1 is be more active. So the recommendation is, at least AHA is saying you want to do about 75 minutes of vigorous aerobic activity. So what does that mean? Typically I tell my patients, hey, I want you to exercise, and this exercise means cardiovascular, cardio exercise, whether it's brisk walking, hiking, walking up the slope, or swimming, or doing a bicycle. And I want them to exercise to the point that they're huffing and puffing, but still be able to maintain the basic conversation with someone next to them during that time. And then stay there for about 10 to 15 minutes. And that is kind of considered to be a vigorous exercise for that person, because you want to be tailored according to the person's capacity. And we want patients to exercise about 4 to 5 times a week. And why do we say that? So in 2022, according to the research, about 1/3 of cancer survivors aged greater than 18 reported no physical activity during their leisure time. Is that bad? Maybe, because there are more research saying that even moderate physical activity can reduce future risk of death. So we're missing it out by not exercising. Not only that, exercise can also prevent fatigue. It can improve energy, cardiovascular fitness, muscle strength, and quality of life. So we really emphasize the value and importance of exercise for our patients. So next thing is control cholesterol. Out of all these cholesterol numbers, I want you to remember LDL, which is a bad cholesterol, and we want LDL to be as low as possible. So why do we care about abnormal cholesterol? It actually happens quite often after transplantation, possibly due to some of the metabolic disturbances and endocrine dysfunction, potential GVHD, and side effects of immunosuppressive medications such as sirolimus. So then what do we do as a person? We want to eat smart, meaning know your fat, and make sure you replace your saturated fat with unsaturated fat. And then any exercise can improve your cholesterol. And if there's still elevated cholesterol despite diet and exercise, it is a time to discuss your cholesterol level with your doctor. The next thing is about managed blood sugar. Similar with the cholesterol, diabetes and prediabetes can happen after transplantation, again, likely due to metabolic disturbances or insulin resistance or inflammation. And like cholesterol, we want to eat smart, but in this case, try to avoid a high carb diet. and also move more and manage weight. And the next item is manage your blood pressure. And I wanted to kind of talk about how to measure blood pressure first. When we talk about blood pressure here, it is a resting blood pressure, meaning you find someone somewhere that's relaxing, sit down, wait for 5 to 10 minutes, rest, and check your blood pressure. It's not after like kind of hiking or exercise, because after exercise, it's very normal physiologic response for your blood pressure to go up. And we want your blood pressure, or resting blood pressure, to be controlled. The reason why we are concerned about elevated blood pressure, because it can happen in the setting of GVHD again, or it can happen after the immunosuppressive medications that people take, or it can also be a sequelae or prior treatments the patient was exposed to that's leading into vasal dysfunction. So in terms of then what do we do? So there's an upper number and a lower number, and just make everything simple and easy. Let's just care about the upper number, and we want the upper number to be less than 130. So, I think a lot of patients actually check their blood pressure at home, and when your upper number are consistently greater than 130, it is time for you to talk to your doctors. Then my patients ask, when do we check blood pressure? Some people check blood pressure once a day in the morning, but unfortunately that doesn't help me as much, because we kind of want to know how your blood pressure trends throughout the day. So what I recommend my patient is that just pick one day every 2 to 3 weeks. And that day, instead of checking one blood pressure, check blood pressure multiple times throughout the day to see what the trends are. That'll be really helpful for us to know the blood pressure trend and see whether any blood pressure medication optimization is needed. Additionally, like other risk factors, we gotta eat smart, because any salt can also increase your blood pressure. And exercise, as always, is the answer. And then, if possible, monitoring blood pressure at home is useful. And again, when it's elevated, then discuss with your doctors in terms of way to lower your blood pressure. Then why do I care so much about these risk factors? Hypertension, high cholesterol, and diabetes. But this is actually the research done by Dr. Armenian here, who is the director of the survivorship clinic. What he found is that if somebody had a prior exposure to cardiotoxic therapy and have these risk factors like hypertension, which is in blue, or diabetes, which is in orange, their risk of heart failure is much, much higher. And this is something that we can prevent it and we can control at home, as well as with your doctors. That's why we want to focus on this controllable, modifiable risk factors that we can work on. So in summary, how do we avoid cardiovascular complications? It is important to be aware of some of the cardiovascular diseases that can happen during and after transplantation, such as atrial fibrillation and heart failure. And it is important to practice life essential aid, as we discussed, that's recommended by American Heart Association. And know your symptoms, look at your symptoms. There's no silly question. Always ask your doctors if there are any concerns about your symptoms. So lastly, if I have time, I will just very, very briefly talk about then what's going on at City of Hope regarding the heart health after transplantation. And this is actually done with Dr. Sarah Armenian, again, who is a director of the survivorship clinic. So probably you heard about this again. It's about clonal hematopoiesis, but it's a little bit different from what you are familiar with as such in MDS. So as you know, there can be a mutation in the stem cells, bone marrow stem cells, but not at the point they becomes MDS, not at the point they becomes cancerous. So we call that as an indeterminate potential. And until recently, we didn't really care much, but we knew that it can happen in the setting of aging, inflammation, or any toxin exposure. But what the research showed us so far is that while a small subset of these patients with CHIP progress to leukemia or other diseases, majority of patients actually suffer from aging-related complications such as heart failure or heart attack. So there seems to be a lot of important association with the heart complications. And so people looked into who is at risk for CHIP, again, like the state before the MDS. And they realized that any prior exposure to chemotherapy or radiation can be a major risk factor for CHIP. And for sure, like when we looked into patients with cancer compared to patients without cancer, which is the blue, we see a much higher incidence of CHIP among the patients with prior cancer. So what we decided to do is to look into, I guess, the rate of cardiovascular disease among the patients with CHIP versus no CHIP. In this case, we decided to study multiple myeloma patients who are undergoing autologous transplantations. This is a little bit different from allogeneic and a little bit different from MDS, but this is our proof of concept study. We saw that patients with CHIP versus no CHIP were much at a higher risk for cardiovascular complication at 5 years. And that it was applicable for across all different types of cardiovascular complications like heart dysfunction, heart attack, and stroke. So we think that this could be a really good biomarker, not only for multiple myeloma patients, but for many other patients with different hematologic conditions, both undergoing either allogeneic or autologous transplantation. So we're really broadening and expanding our studies. So we're studying the mechanisms in terms of how CHIP is causing cardiovascular diseases. Then the next one is how we can then treat it and then explore therapeutic implications. And again, try to apply in a broader cancer populations. So in summary, hopefully you aren't too bored about the talk, but patients treated with transplantation can be at an increased risk of developing heart diseases such as atrial fibrillation and heart failure. And many of these are preventable, and it is important to practice AHA Life Essential 8 to really focus on exercise as well as preventing any modifiable cardiovascular risk factors such as hypertension, high cholesterol, and diabetes. And lastly, we think that CHIP could be a potential novel biomarker in the future, so watch out on the research. This is my end of the talk, and I welcome any questions.
Are there any instances where you've seen patients prior to transplant and you have not recommended BMT because of the state of their heart?
Yeah, so that's actually a very, it's a more multidisciplinary comprehensive evaluation that we do. Generally, if somebody has, like as remarkable heart dysfunction as measured by echocardiography and ejection fraction, or any severe coronary artery disease, then it is something that we try to reverse it if possible, and if not, then sometimes we will look for another alternative treatment. So atrial fibrillation generally is a high heart rate, but especially in the elderly patients where there could be some disease in the conduction of the electrical circuit, it can also cause low heart rate. So it's something that we are looking out to. Yes. Uh-huh. Yeah, it is. It is more in the context of obesity. So obesity, diet, like high-fat diet and inflammation, they're all considered to be risk factors for CHIP. It's all like, the only thing is it's association studies, right? We haven't really proven the causality, but we see more where if patients are either obese or having diabetes or having like more fatty food diet, and CHIP was found to be higher. Yeah. I actually think that 3 months or maybe up to 1 year is really important to focus on your nutritional health and make sure you're not losing weight, you're getting enough calorie. Because a lot of times, you may feel nausea, you can have diarrhea. So it's important to provide enough calories that we need. And then if you don't, and if ice cream is what you want, then yes, you need to have calories first. Oh, okay. I meant low-fat ice cream. But I think once you're at a kind of you survive it, once you go through the 1 year and then you're at a steady state, and I think that is really maybe a good time for you to think about heart health. Because I don't want people to forget about their heart, because heart is one of the important organs in the body, in my opinion. So then it's really time point to think about your cholesterol, your blood pressure. But until then, like, let's focus on to make sure you're healthy. You can go back to your baseline activities and you can eat well. Any other questions? Okay, awesome. Thank you so much.
Thank you so much, Dr. Rhee, for sharing your time and expertise with us this morning.